From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello and welcome to our listeners around the world. You're listening to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Collaborative Care for Opiate Use Disorder in Primary Care, a hybrid type 2 cluster randomized trial. We're about to be joined by Dr. Andrew J. Saxon, MD, and Dr. Anna D. Ratzliff, MD, PhD, both from the Department of Psychiatry and Behavioral Sciences at the School of Medicine at the University of Washington in Seattle, Washington. The opiate crisis has prompted the search for new treatments and programs. While we have talked about collaborative care model on this podcast recently and how it can increase access to mental health services, can that same model, as adapted for opiate use disorder, deliver improved results? To learn more, we'll explore the results in a brand new study just out in JAMA Psychiatry. So thank you so much for joining us, Dr. Saxon and Ratzliff. And maybe to get us started out, you can update us. What is the current state of the opiate crisis and opiate use disorder? Where are we in this?
So it's a very serious problem. In 2022 and 2023, there were over 100,000 deaths from drug overdoses, and about 80% of those were opioid involved. It is true in the year ending in October 2024, there was a decrease by about 20% in the fatal opioid overdoses. So we might be going in the right direction, but it's too early to declare that a trend. So fatal overdoses are one of the most common causes of death in younger people in the United States. So it's definitely a very serious problem.
We know that there's effective medications, but in the paper, you note that less than a quarter or 25% of people with opiate use disorder actually receive these effective medications. That seems paradoxical, or how can that be?
Well, to make a point about how effective they are, for people who have opioid use disorder who are untreated, they have a mortality rate that's 6 to 7 times the general population. When they get on medication for opioid use disorder, their mortality rate drops to about twice that of the general population. So very effective life-saving medications. We don't fully understand why so few people are getting treated. And there probably are a lot of reasons, all of which are somewhat speculation. But I think a big cause is the fragmented nature of our healthcare system, where people have to have different forms of insurance to pay for their medication and pay for the visits to clinicians. And people with opioid use disorder don't necessarily have health insurance or have the resources. Also, until very recently, there was virtually no training in medical school or residency programs for physicians to treat opioid use disorder. And if you don't get trained, you don't know how to do it, you don't feel comfortable doing it. Another reason is stigma. Until very recently, substance use disorder like opioid use disorder was not recognized as a chronic brain disease. It was seen even among medical clinicians as something, a person who doesn't have the willpower to take good care of themselves or to stop using drugs. And there's a lot of self-stigma. People feel ashamed of themselves when they shouldn't necessarily feel ashamed of the fact that they have a brain disease. And of course, that's true throughout all psychiatric illness, but maybe even more for substance use disorders, that maybe keeps people from seeking treatment.
It's a lot of factors, as you said, keeping people away from effective treatment and really effective medications. And that leads me into my next question of one way to perhaps increase access to people receiving services and medications, maybe the collaborative care model, which we've covered on this podcast. Let's quickly review what is the collaborative care model, and perhaps most relevant here, how could it perhaps in its current form be useful? We'll talk about the adaptations in the version you made soon.
Yes. So the collaborative care model is an approach that has been developed and tested and now probably over 100 randomized controlled trials and been shown to be really effective at helping to adapt delivery of mental health services to be able to do that in primary care and other primary medical settings. It really takes a systematic and team-based approach to deliver that care. It typically uses 3 clinicians. One is the primary care provider or primary medical provider, whose role is really to prescribe medications and also really leverage their relationship with that patient to engage them in care. The second member of the team is a behavioral health care manager, typically a master's trained behavioral health provider who both coordinates care and also can deliver brief behavioral interventions right there in primary care, primary medical setting. And the third member of the team is a psychiatric consultant whose role is not to see patients directly, but rather provide support to the team through regular connection with that behavioral health care manager, providing brief systematic case review where they actually can provide both assessment and treatment recommendations to be implemented by the primary care provider.
As you said, it's a very effective model and proven across many systems, many studies. What can we take from the collaborative care model and add to it to kind of help treat the opiate crisis in people with opiate use disorder? What are the modifications or the new parts of the program that we're going to talk about that you looked at?
I think the first thing is really enhanced team capacity to be able to both address opioid use disorder in primary care settings and also deliver the treatment that my colleague also already described as so effective. Some of the main things that we focused on were really increasing the capacity of that team to be able to feel comfortable both prescribing and supporting adherence to medications for opioid use disorder. Second big piece was providing a registry. That's a foundational piece of that systematic part of collaborative care, is having everyone who's enrolled be on a registry and actually be tracking their response to treatment. And for this, we actually introduced a new measure, which we can maybe talk about a little bit later. The third piece is that one of those roles of the behavioral health care manager is to really be able to also support behavioral interventions. And so we developed an adapted form of behavioral activation that was able to be delivered to the patients.
So it sounds like it's collaborative care plus a little bit extra, but it still fits in the main collaborative care model. Is that a good way to summarize it?
Yeah, I would think so. Do you have anything to add, Andy?
You may have already mentioned, but I just want to emphasize that the registry that we developed for the intervention condition to treat opioid use disorder had some components that were not present in the registry used for general mental health care, which was a control condition. So I think that could also add to the benefit for treating opioid use disorder.
Yeah, so specifically, we added this measure called the Opioid Treatment Response Inventory, which was 4 questions that were asked systematically of patients, especially around their response to their medication for opioid use disorder treatment.
We haven't mentioned yet that measurement-based care is a very important component of the collaborative care model and treat to target. So you want to use an instrument that is very carefully measuring how patients are doing with the disorder that you're trying to treat. And then if they're not responding, you want to alter your treatment to try and get response. And so the measure that we designed for opioid use disorder and medication for opioid use disorder was a way to get at that. It's simple. There's 4 items, but if they're not responding on those items, then you want to make a change in the treatment.
In this analogy of the collaborative care plus, we're doing new things. We're going to measure and assess how those new things are going. And so we have this new model. And in the paper, you outlined it. This is a hybrid type 2A cluster randomized trial. And a randomization is done at a clinical level. What do we mean by a hybrid type 2A cluster trial, and why do the randomization at a clinical level?
A hybrid type 2 trial is where you're both testing the effectiveness of an intervention, but also practical implementation approaches to that. So there's a control and an active group, but there is also this attention to implementation. And that's really important because we're really trying to think more as we design studies. And not only do they work, but can we actually get them working at scale out in the real world? So that's a really important part of this trial. The second part is it was done at a cluster approach. And the reason that we did that is because collaborative care is a system-wide intervention, and it would be really hard to have a patient-level randomization within a clinic system that we had trained up to deliver this combined approach for collaborative care, the active intervention group. And so essentially, we wanted patients that were in the systems that we'd trained to do the combined approach to treat both mental health symptoms and opioid use disorder be separate from the clinics where we were focusing on collaborative care only, plus OUD treatment as usual.
And OUD being opiate use disorder.
Yes, thank
Got it.
you.
Yeah. No, that makes sense. If you're building up this collaborative care team, the team is going to be at a clinic level. You're not going to have half the hallway does it and half the hallway doesn't do it.
Right. We were thinking from the beginning, and I think it was true, that stigma and really changing your capacity to address opioid use disorder broadly may have ripple effects within that whole clinic system. And so really thinking about the units of testing being at that clinic level was really important.
How many clinics are we going to be talking about kind of joining or running the intervention in the paper?
Yeah, so there were 42 clinics that were randomized in pairs for the trial. And so it was a large number of clinics all over the United States.
This is a large-scale study by any means. And as we've alluded to, there was an intervention group, and some groups were, again, getting this collaborative care model for opiate use disorder. Some were the control. What were the control clinics if you weren't kind of getting the new version of collaborative care that you guys developed?
All the clinic systems built out the capacity to deliver collaborative care for mental health symptoms and mental health disorders. In fact, most of the clinic systems already had a collaborative care program at the start of the trial. That was one of the criteria we were using to try to recruit clinics, as clinics that had worked with the AIMS Center, which I co-direct. So those treatment teams really were instructed on how to add in the capacity to address OUDs in the active group. So they were the ones that were trained in being able to use this new measure, being able to think about as a team, how do you integrate that approach? The behavioral health care managers were trained in a different behavioral health intervention. And the control clinics, or the usual care clinics, they still delivered collaborative care for mental health symptoms and mental health disorders, but there was no focus on coordinating that with any OUD treatment or opioid use disorder treatment that the patients were receiving. Because that is such a life-saving treatment, we didn't want to not offer that. So all the clinics would offer that in their usual fashion. So some clinics still had a PCP that was able to prescribe that. Other clinics referred to that patient to community resources.
And it sounds like that registry that you were talking about, Andy, that wouldn't be there in the control conditions.
There's a registry, but it doesn't have the added components to help the behavioral health care manager track specific aspects of OUD or opioid use disorder treatment.
And the behavioral health care manager wouldn't have been asking about their opioid use disorder treatment. They wouldn't have been checking in with that. In a typical collaborative care model, that behavioral health care manager is very active in engaging that patient in treatment, often seeing them, a couple of times a month. And so it'd be, fewer opportunities for that check-in from the team to support that opioid use disorder medication.
It's really nice that the control condition was also collaborative care, because you said it's an effective treatment already, and we're adding to it. So we want to make sure that this addition we're going to learn about. So a very nice study design. And we're almost going to get to the exciting results, but let's talk about the primary data collection first, the measures you're using, so listeners will understand what are those main outcomes. And I will say there's so many exciting other outcomes in the paper. I encourage everyone to read it. It's so much good information, but what are the main primary outcomes we should be tracking and looking at?
Yeah, so two co-primary outcomes. One is non-prescribed opioid use. So obviously, one of the targets of treating opioid use disorder is to decrease or stop non-prescribed opioid use. So all the outcomes were collected through patient surveys, and we collected their reports on how many days had they used non-prescribed opioids in the prior 30 days. And second co-primary outcome was mental health-related quality of life, which was obtained through the mental component summary of the SF-12, which is a widely used measure for health-related quality of life.
It makes sense. We want to hope that use of non-prescribed opiates goes down and hopefully quality of life goes up, would be what we would want for anyone. It's a large sample. There's up to 42 clinics involved. How many patients were kind of tracked or part of the study? And can we say anything about the sample in terms of who they were?
Yeah, so there were 254 patients that were enrolled in the two different randomized sets of clinic systems. I think one of the main things to know is that a number of those patients were already taking medications for opioid use disorder at the start of the trial. So I think that has important implications to interpreting the results of the trial. Otherwise, we had very few exclusion criteria. So they were a broad sample of people that represented kind of the breadth of what can show up in primary care. We really only excluded people who basically weren't able to consent for the trial, people that were already receiving specialty mental health or opioid use disorder treatment outside of the clinic at the start of the trial. So, yeah.
So pretty broad, which is good because that means it would fit, say, for my hospital if I implemented it and we could learn. But as we said, the paper has a lot of important and interesting results. Let's maybe talk about the main outcomes is around, as you said, quality of life and non-prescribed opiate use. What were those high-level things that you and the team learned?
In regard to the opioid use outcome, Anna already mentioned many of the patients who participated in the study were already on medication for opioid use disorder when they started their enrollment in the trial. So the levels of non-prescribed opioid use were actually relatively low to begin with. But what we found over a 3-month follow-up and 6-month follow-up was that the number of days of non-prescribed opioid use in the active intervention condition compared to the control condition was reduced significantly more, which is what we would have hypothesized. And so that does show the effectiveness of the intervention in reducing non-prescribed opioid use, which obviously is a very important finding and the value of the intervention. In regard to mental health related quality of life, the way that measure works is the scale is 0 to 100. It's normed as a mean of 50 being a mean for the general population. The patients in our trial started out at an average of about 34. So, and 10 points is considered a standard deviation. So there are 1.5 standard deviations below the average for our country, which is, pretty seriously impaired mental health quality of life. We saw equal improvements in both conditions. So there was not a difference that we would have hypothesized would have occurred in the intervention clinic patients, but they both increased about 4 points. 5 points is considered a clinically meaningful improvement. So we didn't quite get to that, but it was also only a 6-month period. So we're definitely going in the right direction. And it's not that surprising that the control clinic also got better because they were getting collaborative care, this super effective intervention for their mental health symptoms.
As you said, it's going in the right direction, but collaborative care is very effective at baseline too. So you guys picked the hardest control condition, which is also very impressive that things are going. And as you said, we are seeing that decrease in non-prescribed opiate use, which is very critical if we're going to solve this issue. How do you think these results overall can inform how we can better care for patients with opiate use disorder?
It's really important to think about, can we offer this level of systematic care using the measurement-based care, having people that can really wrap around and support people, the active components of collaborative care to help improve the number of people who are accessing this life-saving treatment. So, and I do think it was really important that this study was done in primary medical settings, primary care settings. There was both community settings and academic settings. So I think we really also think that this is something that is at least possible to broadly implement.
Around that, what would it take to kind of bring this level of collaborative care to scale it to different sites? So we said collaborative care has already expanded a lot across the US and the world, but how much work would it take to kind of make this model of care accessible to more Americans?
I really think that collaborative care is a very effective, but it also has some complexity to how you have to deliver care. And so that takes real attention by systems to implement that. It's not as simple as hire a couple people and beautiful things happen. You really have to work as a team to actually figure out how to change the way you deliver care, to be able to do that effectively together, to be able to make sure that the effective components like regular measurement, regular follow-up, actually getting the information and recommendations from the behavioral health team to the primary care provider for implementation. All of those things, those workflows really take a lot of time. So I think to scale this, hopefully it's something that we could think about as people are broadly scaling up collaborative care delivery in general. Could we say, if you have capacity to deliver collaborative care, making sure your team could also address opioid use disorder, I think is a really important strategy to be thinking about this. Because we actually helped some of the clinic systems who already had collaborative care add this in, we have some information about how to be effective about doing that. So, I mean, in the sites that already have collaborative care, adding this capacity could be really helpful. And I will say we found fewer patients than we expected to. So that ability to add this into an established collaborative care program might be really helpful for scalability, because I think trying to build a program just for patients that have opioid use disorder plus mental health systems, you're probably not going to have enough volume to really build a high quality program. So really thinking about this as something that should be one of the capacities maybe of a collaborative care team, I think will be an important strategy for scaling this. And then I'll just say, we need support for this kind of intervention. It takes a lot of upfront cost and investment of systems to build collaborative care capacity. And so thinking about how could payers or states or federal programs actually support the implementation of collaborative care, and maybe emphasizing the importance of including this capacity to address opioid use disorder might be really important.
It's wonderful to have things that are helping with the opiate crisis, and this is one of them that does seem to have positive results. Any final words, Andy, that you want to give us on just these medications or how they're effective, or anything you would want clinicians to just keep in mind as they go forward?
Just a reminder that everyone who has an active DEA license is able to prescribe buprenorphine for opioid use disorder. And it's a fairly straightforward thing to do. Anyone who's a psychiatrist who handles chronic psychiatric conditions, this is just another chronic psychiatric condition. You can do any other part of psychiatry. You can treat opioid use disorder. And we would encourage, whether it's in collaborative care or outside of collaborative care, we would encourage everyone to identify and treat their patients who have opioid use disorder.
Yeah, and I will just add that I think that measure that we created for this to help support systematic adjustment of treatment, that measurement-based care is shown to be a really effective strategy, even with outside of the context of collaborative care. So I would encourage anyone to consider using measurement along with prescribing to really make sure you're optimizing that treatment for patients.
Those are both practical and things that people can implement today. So a nice note to end on. Again, I'm Dr. John Torous, and I've been speaking with Dr. Andrew Saxon, MD, and Dr. Anna Ratzliff, MD, PhD, about collaborative care for opiate use disorder in primary care, a hybrid type 2 cluster randomized trial. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.